Good morning, people from Atlanta. This is an MS Views and News program. My name is Stuart. I'm president and founder of MS Views and News. This program is far different than anything we've ever done, and this is a trial program. We're hoping that people in the audience that are online, as well as those that are here, can appreciate what we're doing here. This program is more about NMOSD, which is a very rare disease, than it is for multiple sclerosis. And there are people that have been misdiagnosed over the years with MS that actually have NMOSD, but we're here today to learn the differences between NMOSD and multiple sclerosis. And for today's program, we're sponsored by Alexion Pharmaceuticals. About Dr. Mitzi Williams. She's board-certified neurologist and fellowship-trained multiple sclerosis specialist who serves as the founder and CEO of the Joy Life Wellness Group Multiple Sclerosis Center in Smyrna, Georgia. She's considered a subject matter expert in neurology, multiple sclerosis, and health disparities. Dr. Williams has over 15 years of experience in the field of MS. She received her undergraduate degree in neurosciences and behavioral biology from Emory University in Atlanta, Georgia. We have a whole page and a half I could do about Dr. Williams. We don't have time for that today. Let's just come on up here and let's get this started, all right?
How is everybody doing? It is so good to see friends. It is so good to see familiar faces as well as new faces. So I hated to steal the thunder, but I'm going to answer a lot of the questions that you guys had in my presentation. So you got to give me something to talk about, right? Okay. All right. Basically, the goal of this is I'm going to talk about some of the central nervous system demyelinating diseases and how we tell those apart. So a good deal of it is kind of what are the difference between NMOSD and MS. And then we'll talk a little bit about treatments. Okay. So let's get into it. Let's think about autoimmune disease, right? So when we think about NMOSD, we think about MS, we think about autoimmune disease. What does that really mean? An autoimmune disease is a disease where the immune system, the part of the body that normally attacks viruses and bacteria, gets confused and attacks a good part of the body. So when we think about autoimmune diseases, each of these diseases has a different target, right? So here on this graphic, we see some words like lupus standing out. We see type 1 diabetes, we see SLE, we also see rheumatoid arthritis. We also see MS. So with all of these diseases, a different target or different part of the body or certain parts of the body are being attacked. And with MS and NMOSD, we're thinking about the central nervous system or the myelin, the coating of the nerves, okay? But some of the things that these autoimmune diseases have in common are, number one, that your immune system is doing the most, okay? So it's doing stuff it's supposed to do, but also doing things it's not supposed to do. There is inflammation. Okay, so many of the treatments for different flare-ups of lupus, MS overlap, right? So everybody uses lots of steroids, okay? Everybody's familiar with steroids. But also we know these are more common in women than men, okay? So that's something we see across most autoimmune diseases, okay? And even though we see that side that says cannot be cured, right? That's one of the things that can be a little bit discouraging when we talk about MS and NMOSD. Is there a cure, right? But my response to that is usually, name me 5 diseases that are curable. 5. I'll wait. We're going to be here until Christmas, right? Okay, so we do not cure diseases often in medicine, but we do control or manage, right? So right under cannot be cured, can be controlled or managed, right? And our ability to manage these diseases has improved significantly over the past couple decades, all right? And we'll talk a little bit more about that. All right, so this is another slide that's looking a little bit about the immune system attack on the central nervous system, okay? And here at the bottom, we see some common autoimmune diseases. You see MS is listed first, but also allergies can have an autoimmune pathology. I don't know, but I live in Georgia and I got horrible allergies, right? Then we think about other connective tissue diseases like scleroderma. The skin can be attacked. Celiac disease, we see the stomach with type 1 diabetes, the pancreas, and then with rheumatoid arthritis, the joints. So remember, each disease has a different target or attack. But if we take our focus back to the top of this, we see on the left side here a normal nerve cell. Okay, so we can see the myelin sheath, those like little round red things. Okay, and then we see the T cells. Okay, so we have a couple of major players in the immune system attack. For anybody who's been in clinic with me, I like to draw pictures and I like to make hip hop analogies. Okay, so the T cells are what I call the attack dogs, right? So we see our T cells over here in the normal cell attacking a virus. Okay, the little green thing is a virus. Y'all with me? Yes, no, maybe so. Y'all with me? Okay, talk to me. Okay, so I know you're with me. All right, so we see the T cells attacking the virus. Those are the attack dogs, right? The B cells are what I call the hype men, all right? So the B cells encourage or hype up the T cells to attack you, right? So for my old school hip hop analogies, we got Chuck D and Flavor Flav, right? So T cells are Chuck, B cells are Flavor, right? Or Busta Rhymes and Spliff Star, right? Busta's on tour. He just got a new album that came out, right? So Busta Rhymes, right? Doing all the work, attacking, right? And then Spliff Star is hyping him up, okay? Or if you like R&B analogies, James Brown and Maceo, right? So James, right, is doing the work and then Maceo is hyping him up, okay? So the B cells are not listed here, but when we go to the next slide and look at some of the cells that are involved in these different autoimmune diseases, you will see B cells listed. So we got our normal cells, right? We got our normal immune nerve on the right side, I guess the right side, or maybe the left side from where you're sitting. Okay, so it's attacking a virus. Okay, but then we look over at the confused cell, right? And we see some of those T cells, the purple ones, are what we call autoreactive. Okay, so they become activated and start doing stuff they're not supposed to do. And we see those autoreactive cells attacking the myelin or the coating of the nerves. And that's what leads to the dysfunction with multiple sclerosis, okay, is the attack of the nerves. Now, with NMOSD, the mechanism is a little bit similar, but it's a little bit different. And we'll go into a little bit more detail about that. All right, does that make sense to everybody? Yes, no, maybe so. Got a mouthful of food. Stop bothering me, Dr. Mitzi. All right, let's go. All right, so demyelination. Okay, so again, the underlying issue that causes the symptoms with NMO, with MS, other CNS diseases is demyelination. Okay, so that's the downstream effect. And so when those nerves are demyelinated, what myelin does is it makes the signals run more quickly. All right, so that when you want to put your knife in that piece of chicken and cut that chicken up so you can eat it, right? Your body does what your mind tells it to do. When those signals are interrupted, a couple of things can happen. So if the signals are slightly interrupted, then sometimes your nerves will work normally, but then under certain circumstances or pressure, they won't act normally, like stress. If you're overheated, right? So while you're sitting here in a cool room, just kind of chilling and relaxing, everything works like it's supposed to. You go out in the Georgia heat and sunbathe for a couple hours, or you go out to a picnic, and then those nerves don't work like they're supposed to, okay? In other instances, if there's a little bit more severe damage, then those nerves won't work like they're supposed to all the time, right? So you may be a little bit slower in doing certain things, or you may not be able to feel normally, all right? And then in severe cases, the myelin is damaged and the nerves are cut or severed, so the signal is interrupted and things don't work at all, okay? And that's more of what we call permanent disability or permanent symptoms, either from a relapse or from progression of disease, okay? So basically, when we look at demyelination, there are a couple of different levels of severity. The difficulty is when we look at your MRIs, all of it shows up white. Okay, so it's white, whether it's a little bit of damage, whether it's a little bit more severe damage, or whether it's very severe damage. Okay, so it all looks white to us. So we can't really differentiate that just by looking at imaging. Pathology, I'm not going to go into a lot of detail about this, but again, just looking at kind of three of the most common central nervous system demyelinating diseases, we have multiple sclerosis, okay, we have NMOSD, okay, and then we have ADEM. ADEM is a condition that we see primarily in kids, okay, and it is very severe demyelination throughout the brain in usually at the same time. So it's usually kind of younger people that present and are very, very confused, you know, not typical of what we see with MS and NMOSD, where people often are not acutely confused, but have, you know, certain neurologic symptoms. So we see some of the cells are very much the same, okay? The infiltrating leukocytes or white cells, we see T cells and we see B cells involved in all three of these, okay? So again, many of the major players of different types of cells is very very similar between these diseases, but the way they manifest with symptoms and the way that we understand them is a little bit different. Again, this is another slide just showing a little bit of the difference between these CNS demyelinating diseases. So we'll start at the bottom in the blue with MS, okay? So the clinical syndrome of MS is usually optic neuritis, or people will have transverse myelitis. Honestly, I didn't create this, so I don't know what the BS stands for, but a lot of people say their MS is BS, right? So I guess BS is a part of MS. All right, so optic neuritis and transverse myelitis, okay? MRI has very typical lesions that we'll look at later, okay? In the spinal fluid, or CSF, with MS, we often see something called oligoclonal bands. Anybody heard of those bands? Yes, no, maybe so. Nobody heard of bands? No. Okay. Well, if you got a spinal tap, that's what your doctor was looking for. Okay. So we're looking for bands, which are basically immune cells or antibodies that tell us your immune system is overactive, right? Because the only way to tell 100% what a lesion is on your brain is to do a biopsy, which we're not going to do, right? We're not doing brain biopsies if we don't have to. So basically that spinal fluid swims around your brain and your spinal cord. And when we examine that, it gives us an idea of what's going on in the brain space. Okay. So we look for things like infection. We look for things like signs of overactive immune system. And we look for things like, for instance, cancer in some cases. So all those things we look at in the spinal fluid because we don't want to take pieces of people's brains and spinal cords out if we don't have to. Okay. And then in terms of antibodies, there are no antibodies for MS. Okay. So we would not expect the antibodies for NMOSD to be positive in someone with MS. We would expect them to be negative. All right. Now let's go up to the yellow and let's look at neuromyelitis optica. Okay. So clinical syndrome, same symptoms as MS, optic neuritis, transverse myelitis, and BS. Okay. So, but the MRI does not look the same as MS. And we'll talk about that in a little bit. When we look at the spinal fluid, we don't typically see those bands. Okay. That's something that's really common with MS, much less common in NMOSD. So that is one of the ways that we differentiate the two diseases. And then, as Erica mentioned, about 73% of folks with NMOSD will be aquaporin antibody positive, aquaporin 4 antibody positive. And that's a blood test that we do to determine if somebody has NMOSD. Now, if that antibody test is negative, it doesn't mean a person doesn't have NMOSD, okay? But the majority of people do have a positive test. And that does affect our ability to treat, or what options we have to treat NMOSD. Okay. And then the newest player on the block is in the green, anti-MOG associated disorder. Okay. So this is a new antibody that really was just discovered probably in the past decade or so. And so some people who we thought had NMO spectrum disorder actually may have had anti-MOG antibody disorder. Okay. So that's a separate antibody. Again, the symptoms can be very similar to MS and NMOSD. Okay, but they have a different type of antibody that they're positive for. Also, this syndrome overlaps a little bit more with the ADEM, the syndrome we talked about that happens in children. Okay, so again, when someone comes with symptoms of demyelinating disease in the central nervous system, these are often antibodies that we screen for to kind of see which category you fit in. All right, which will determine the best treatment options. Okay, and then listed here in the bottom in the red, orange, brown, I don't know what color that is, are other demyelinating syndromes, okay? So this can include things like ADEM that does not fit in that MOG disorder, or there are some people who will have what we call idiopathic transverse myelitis, meaning they just have transverse myelitis, we don't know why they got it, and they may not have it again, okay? So there are other diseases that kind of fit in that category as well. Okay, so when we think about the differential diagnosis, okay, and we think about how do we tell the difference between MS and NMOSD, I'll go into the history a little bit later, but for a long time, we considered NMOSD a part of MS or a subcategory of MS, and it was not really determined to be a completely separate disease from MS until the early 2000s. Okay, so a lot of the knowledge that we have has just come like in the past 10 to 15 years or so. Okay. So when we think about how do we differentiate MS from NMOSD, there are a couple things that we look at. So there's some clinical features or symptoms that are a little bit more typical of NMOSD than MS, okay? One of them is bilateral optic neuritis, okay? Many people with MS will have optic neuritis or loss of vision, but it'll be one eye, and then maybe a year later, it'll be the other eye, okay? But usually with MS, it's not both eyes at the same time, okay? That's a little bit more typical of what we see with NMOSD. Often we can also see severe brainstem involvement. So the bottom part of the brain, okay, which controls many of our automatic functions. Often we can see very large lesions in the brainstem with NMOSD that we may not see in the very beginning of MS. Also, when we look at the spinal cord, and we'll see some images a little bit later, we can see really long damage or lesions in the spinal cord. With MS, we may see a bunch of very short lesions, right? So you may have 4 or 5 spots, but they're kind of small spots versus one very long spot, okay, that covers several segments of the spinal cord. And then when we look at the brain, we previously thought NMOSD did not involve the brain, but we do know now that there can be brain lesions involved, but sometimes they're big. Sometimes they almost look like tumors, right? So we used to call it tumefactive MS before we thought of it as a separate disease. And so we've had many patients who've had lesions that look like a tumor who have gotten a biopsy because we're like, is this cancer? But it actually was NMOSD. Okay. And then also there are antibodies, remember, that we check. Okay. And these are blood tests. We look for aquaporin 4 antibody and also anti-MOG antibody. Okay. All right, so principles of diagnosing MS. How do we know if something is MS? So again, we look for lesions or disease or damage to the central nervous system that's separated in space and time. Basically, that means different parts of your central nervous system, the eye and maybe another part of the brain, or the brain and another part of the spine. So different spaces within the CNS, and that has to be over time, right? So, a lesion that developed at this point, and then a lesion that developed later. So we have to have that separation of space and time. We also look at clinical findings. MRI is the biggest way that we diagnose both of these diseases primarily. In some cases, we do lumbar punctures. We don't do them as commonly as we used to. We used to get LPs on everybody. We don't do them as commonly, but they are still used, especially if we need to really differentiate between a couple of different diseases. And then sometimes there are other supplementary tests. And then I think one of the most important pieces is that we have to exclude other diagnoses. So both of these conditions are considered diagnoses of exclusion. So we have to make sure that we're looking to see if you have another rheumatologic disease that may be causing some of these issues, or make sure that we're ruling out other reasonable causes for you to have these symptoms. All right, so what are kind of red flags that tell us about, so this is kind of similar to the last one, but let's say someone goes to the doctor and we're concerned about MS. These are some of the red flags that tell us maybe we should be looking at NMOSD versus MS. Okay, so again, we said bilateral optic neuritis is more typical of NMOSD. Okay. Both eyes at the same time. And then the other piece is that there often is poor recovery from relapses. So with MS, oftentimes when someone has their first optic neuritis, their vision nearly gets completely better, or they have significant improvement with vision. With NMOSD, in many cases, we have very poor recovery of vision. So you may have the optic neuritis, but it doesn't get better. So for instance, I had a 25-year-old patient who within a year was blind, okay, because it wasn't recognized as NMOSD. And so she lost the vision in one eye and then in the other. But with MS, there often is better recovery than with NMOSD. And then when we talk about transverse myelitis, which is damage to the spinal cord, again, often more severe relapses with NMOSD. So with MS, people will often have a transverse myelitis and they may have, let's say, numbness in both legs, but usually one side is affected more than the other. So even if both sides are affected, someone will say my right side is my bad side or my left side is my bad side. With NMOSD, we more commonly see both sides equally affected, and again, very severe symptoms without significant recovery or with very little recovery. Okay. Other things that are red flags that kind of lead us, maybe this is not MS, is if people have what we call gaze palsy, like one eye is not moving like it's supposed to. Okay. Also, if people have nausea, vomiting, or hiccups, that's a particular area of the brain that's affected called the area postrema. And we see that very commonly with NMOSD, where people will have nausea and vomiting that just won't go away. Okay. And it's because their brain is affected. And I've had many people who've gone to the ER and been told they had GI issues or whatever, and they didn't get the brain MRI. When we finally got the brain MRI, we saw that it was a brain problem and not a GI problem. And then, of course, if someone has encephalopathy, meaning they're really confused, like don't know what's going on in terms of like hospitalized, altered mental status, that's not typical of MS. Relapses, and then if someone has pretty significant cognitive decline that happens rapidly. Okay, so with MS, we see a lot of cognitive issues, but often occurs slowly over time. If someone this week could do what they were supposed to do and next week can't work because they're so confused, that's not typical of MS. All right. So what are some of the other things that we look for, right? So when you go in for that diagnosis of MS and you come to our clinic and our phlebotomist drains you of all your blood, okay, it's for a reason. And we're looking for many of these other conditions, right? So the most common one is if we're concerned about demyelination, we're looking to make sure we don't think it's NMOSD. Often we check your thyroid to make sure it's not hypo or hyperthyroidism, because that can sometimes cause neurologic symptoms. Also, if someone has, let's say, a vitamin B12 deficiency, it can sometimes cause issues with numbness or tingling or damage to the spinal cord if it's very severe. So usually we do screening for a bunch of different conditions to make sure that there's not, again, another reasonable cause for the symptoms. All right. And then these are some of the tests that we do. Most of these are blood tests. So oftentimes we'll check for rheumatoid arthritis. We'll check for lupus. We'll look at the thyroid. We'll look at B12. OK. We'll do screening for some infections. OK. And we'll do other tests, again, to rule out other reasonable causes of the symptoms. All right. So a little bit more detail about NMO. All right. So again, is a CNS demyelinating disease. We know that the most common symptoms are optic neuritis, which we'll talk a little bit about, and longitudinally extensive spinal cord lesions, so transverse myelitis. Okay. Also, what we know now is that there are brain syndromes that can occur. So when we look at the evolution of the diagnostic criteria for NMOSD, it used to be you couldn't have any brain symptoms or brain lesions, but now we know that brain syndromes and brain lesions can occur. Most commonly, it's relapsing, so people will have relapses, and those relapses, as we said, can have severe disability. So it's extremely important to prevent relapses in MS and NMOSD, okay, but those relapses can be absolutely devastating with NMOSD. So we really want to prevent relapses because there often is very poor recovery from them. All right. And then again, we talked about how it is more common in women than men, but a little more common in women with NMOSD than with MS. All right, so a little bit about the disease itself. So about 90% of cases are relapsing, okay? And again, those attacks are what lead to the disability. 76% of patients did not make a complete recovery after their first episode of transverse myelitis or optic neuritis. It does affect about 2 out of 100,000 Caucasians or white people, but the prevalence is much higher in Black and Asian populations overall. Okay. So with MS, we've seen a lot of data about the increase in MS we've seen in Black populations here in the US, but worldwide is thought to be most common in white populations, primarily in Eastern Europe. With NMOSD is more common in Black and Asian people. Okay. Period. All right. And then the onset is usually around the age of 39 years. And I think the point at the bottom is really important because MS is generally a progressive and relapsing disease. NMOSD is really more, the progression is related directly to the relapses, okay? So with NMOSD, you have a relapse, you don't recover, that's where your disability comes from. We also see that with MS, but in addition with MS, we see progression without relapses, right? So that's people that are not having relapses, but they're coming in and saying they're getting worse. We don't really see that with NMOSD, okay? So that's another differentiator, is that MS is progressive without relapses, recurrences versus with NMOSD, most of the disability comes from the relapses. Okay, so aquaporin 4, I'm not going to go through all of this, but listen, it's a channel, okay? It's a water channel, okay? And it's on certain cells called astrocytes. So when we were talking about those major players, right, the attack dogs and the hype men, okay, this is a different type of cell where a lot of the issue occurs with NMOSD. So the astrocytes are in the central nervous system, and this channel is on these astrocytes. And so when this is affected, it can lead to demyelination as a downstream effect. Okay. Another major difference is that with NMOSD, we have an antibody we can check, and we don't have that for MS. Okay. So we understand a little bit more about the target with NMOSD, but we don't yet know the target of attack with MS. We also don't understand triggers for either one of these diseases. So we don't know kind of what kicks it off, what gets it started, or what starts this process for either disease. So we still have a lot that we need to understand. Okay, so let's talk about the evolution of NMOSD. So someone asked, when was it first recognized, right? So who remembers when MS was first recognized as a disease? If you heard me give a talk before, I gave you this. 1860, come on, y'all making me look bad. 1868. Write it down somewhere. Okay. 1868 was when MS was first recognized as a disease. Okay. So what we now call NMO and previously called DeVick's disease was first recognized in 1894. Okay. But remember, in the beginning, it was thought to be a subcategory of MS. And so 1894, it was first recognized in a patient who had optic neuritis, okay, vision loss, transverse myelitis, spinal cord problem, but no brain lesions, okay? So when the diagnostic criteria first came around, it used to be that you couldn't have brain disease because that was thought to be a totally separate thing from MS. Okay, so that's 1999. Optic neuritis, transverse myelitis, no other brain disease. 2006, still the same. Okay, 2007, still the same. Plus now we got an antibody we can check. But by the time we get to 2015, we recognize that there are some brain syndromes. Okay, so the diagnostic criteria for NMOSD includes the optic neuritis, the transverse myelitis, the antibody, but there are also criteria for people who don't have the antibody. Okay, and also we recognize that there are brain syndromes that can occur. But what you see at the bottom of the one from 2015, again, is similar to what we see with MS, exclusion of alternative diagnoses. So we have to make sure that we're not missing something that could be another explanation for these symptoms. All right, so when we think about symptoms, all right, this is a little bit more detail about NMOSD. So again, vision loss, optic neuritis can often cause blindness in our patients, sometimes because of damage to the brainstem, the bottom part of the brain where we see a lot of our automatic functions. People can have respiratory failure. We do not typically see that with MS, okay? Also, because of damage to the spinal cord, you can see loss of bowel or bladder function, also symptoms we can see with MS. And then remember, the hiccups, the nausea, and the vomiting are a little bit more typical of a certain syndrome, brain syndrome that can occur with NMOSD versus MS. Okay. And then of course, people can have paralysis, pain, spasms in their extremities, weakness, loss of sensation. And then people can also have cognitive problems and seizures, but we don't see cognitive problems as commonly with NMOSD because it tends to have less brain involvement. Does that make sense? Okay. I know I'm laying it on thick here. All right. All right, so optic neuritis, let's talk about this in a little bit more detail. So optic neuritis can actually have a variety of symptoms, right? So typically we think of vision loss, but there are other effects to the vision that can occur with optic neuritis. Many people will have pain in the eye, pain with movement of the eye. Also, you can have partial loss of vision or blind spots in the vision. Sometimes the vision is blurred. People tell me it looks like they're looking through like frosted glass, right? Or through like raindrops or something like that. Also, there can be loss of color vision. Some people will have difficulty with color vision as well. So those are all symptoms that can occur as a part of optic neuritis. And we can see here the normal eye on your left, your left. Okay. All right. My other left. Okay. So we can see the normal eye, right? We can see the myelin, the little purple things, right? And then on the optic neuritis eye, again, we see damage to the myelin and inflammation of the nerve. And oftentimes, if that's acute, we can also see it on MRI with enhancement. Okay. All right, transverse myelitis, I forgot to put the symptoms down here, but transverse myelitis, I told Stuart, he made me work for this one. You know, this is my first full NMOSD presentation that I had to make up myself. So I was working yesterday, y'all. Listen, I was looking up articles and all kind of stuff. All right, so, but transverse myelitis symptoms are often numbness, weakness, spasms, pain, right? Loss of bowel and bladder function, again, similar to what we see with MS, but sometimes it can be more severe with poor recovery. All right, so let's talk about MRI. So when we look at MRI findings with MS, there's certain types of lesions that we see. So they're called periventricular, right? So everybody's got a big hole in the middle of their head, these ventricles, these fluid-filled spaces. And so we see lesions or white spots that are right next to those ventricles with MS, okay? We can see they're kind of small lesions, they're kind of ovals, you know, and then in the spinal cord, which I don't have a spinal cord picture here, the lesions that we see in the spinal cord are often short and kind of small. All right. And then with NMOSD, we can see in the brain, the lesions look a little bit different and everything is pointing to an arrow. So we can see lesions in the spinal, in the brain stem. Okay. So these bottom parts of the brain. We can see lesions in this area here. The area postrema is D. Okay. And then in the spinal cord, we can see the white area in the spinal cord is really long. Okay. So can you guys see that? This is the lesion. You see how long that is? Okay. So with MS, the lesions are usually short, like one segment. Okay. But we can see this really, really long, broad lesion in the spinal cord, and that's more typical of NMOSD. Okay. Lumbar puncture. What's the role of lumbar puncture? Who's had a lumbar puncture? Okay, who doesn't remember if they had a lumbar puncture? I was about to say, you ain't have one if you don't remember. You would not forget it if you had it, okay? Because I was like, I have some patients come out and say, did you have an LP? They're like, I don't know. I'm like, you didn't have it. If you don't know, you didn't have it, okay? But again, so we don't always do lumbar punctures like we used to because the imaging techniques have gotten significantly better, right, over time. So sometimes we'll get MRIs and we're like, this is a really classic looking MRI. We don't need to do a spinal tap, but in some cases we do. All right, and so again, what we're looking for is those oligoclonal bands, okay? We're also looking for things like infection. We're looking at protein, glucose, etc. With NMOSD, 80% of people do not have oligoclonal bands, whereas with MS, 90% of patients do have oligoclonal bands, okay? And then we also only see oligoclonal bands in a small percentage of those with MOGAD disease, all right? And this is just one slide about MOG antibody syndrome, MOGAD disease. So basically, it is an autoimmune disease. It's relapsing. It's inflammatory. Again, the optic nerve and the spinal cord are affected. It can be confused with NMOSD, and it also can be confused with ADEM, the CNS demyelinating disease we see in children. It is treated very similarly to NMOSD. Okay, but again, if someone has a negative antibody for anti-aquaporin 4, the MOGAD antibody is another antibody that we can check to see if they have that syndrome. Okay, so when we think about relapses and progression, again, the progression or disability we see associated with NMOSD is very much associated with the relapses, which also occurs with MS, but with MS, we see progression without relapses. So again, people can have very severe disabling disease from NMOSD, which is why we want to make sure that we diagnose it correctly and that we treat it very early. All right, so also looking at NMOSD in ethnic minority populations, as we discussed, MS is very broadly thought to be a disease primarily of people of Northern European descent, although we see those numbers and statistics changing in the U.S. When we think about NMOSD, the cases are much higher in Black and Asian populations versus white populations. Okay, so what about treatments? The other thing that's important is to recognize that we want to differentiate the two because some MS treatments can worsen NMOSD. And so when these were similar or thought to be under the same category, many, people had to find this out the hard way because we just didn't know. They weren't separate diseases. So some of the interferons, okay, natalizumab, as well as fingolimod can worsen NMOSD. So again, important to differentiate the two to make sure that we're treating people appropriately. All right, so what are treatments? All right, so I'm not going to go into a whole bunch of detail about these, but the treatment of this condition has changed drastically over the past 5 years. So we didn't have the first FDA approved treatment for NMOSD until 2019. Okay. But there were treatments that we used. Again, some of these overlap with what our rheumatology colleagues use for other autoimmune diseases. So in the treatment of relapse, which I don't have listed here, relapse treatment is very similar to what we do with MS relapses, a treat with high dose steroids. But in NMOSD, if high dose steroids don't work, there often is a procedure called plasma exchange that is used. Okay. And this is something where people have to get hospitalized usually, and they receive treatment that kind of decreases those antibodies in the blood. So it's kind of similar to dialysis, but kind of not similar. All right. But that's something that's used more commonly for NMOSD relapses. Again, because it can be so disabling, we don't use that as commonly with MS. All right. And then once people are treated for a relapse, then there are different things that we use. So there are 3 FDA approved treatments, which are listed at the bottom here. But prior to FDA approved treatments, we often use rituximab, which is a treatment used for MS. We use it for just about everything. So rituximab has been used in cancer and rheumatologic diseases as well as MS, and was the primary treatment we used for NMOSD before FDA approved treatments were available. And for patients who don't have positive antibodies, it still is a very common disease, because a common treatment, because the FDA approved treatments can only be used if a person is antibody positive. Okay. So for those people who are not antibody positive, we have to use some of those other treatments. And then there are a couple of other treatments like at the top 2, azathioprine and mycophenolate mofetil, which are oral therapies that we've also used for NMOSD prior to FDA approved treatments. All right. And then these are the 3 FDA approved treatments, again, for people who are antibody positive. Erica gave us a nice discussion about eculizumab, which is the first one. It's an infusion that's given on maintenance every 2 weeks. Inalizumab is a anti-B cell therapy, which is a little bit similar to some of our B cell therapies that we use for MS, and it's given once every 6 months after a first course where they get an infusion and then another infusion 2 weeks later. It's given every 6 months. And then satralizumab is a subcutaneous treatment that on maintenance is given every 4 weeks. Okay. So with any of these treatments, again, screening for infection, possible side effects could include infection as well as, upper respiratory issues, infusion reactions, etc. Okay, so last couple slides. I think some of the most important things that we have to focus on is comprehensive care, right? And so again, as we're learning more about treatments, as we're learning how to manage these conditions, now that we have different treatments, it gives us more an opportunity to focus on the whole person, right? So again, in the beginning, we're all focused on how do we stop these relapses? How do we get these under control? We may not have paid as much attention to looking at things comprehensively. So again, when we talk about a comprehensive care team, it's important to remember that you are the center of your team. You are the most important member of your team. Okay. And although you have many experts who are experts on many things, I'm the expert in neuroimmunology, you are the best expert on your own body and your disease. Okay. And we don't know what to do unless we get information from you about how you're doing, how you're reacting to treatments, to tell us if we're still doing the right thing or if we need to come up with a new treatment plan. And some of the other members of your team are primary care physicians, okay, which everybody should have a PCP, because your neurologist does not want to look in your nose, okay, or your ears, right? So I would have to dust off my, my otoscope to look in your ear, okay? And then half the time I still don't know what I'm looking at, all right? So you want to have a primary care, all right? And then, of course, depending on the symptoms or issues you have related to your MS, depends on who else comprises your team, right? For some people, there may be other specialists, like a urologist if you have bowel or bladder issues, rehabilitation specialists like our physical therapists, occupational therapists, speech therapists, etc. The mental health professionals, right, which can help with symptoms like anxiety, depression, which may occur more commonly in people with MS and NMOSD. But again, the most important thing is you can create your own team. If members of your team are not doing what they need to do, or you don't feel comfortable, you can always get a second, third opinion. All right. And so optimizing care means speaking up for yourself, advocating for yourself. And if you're not getting what you need, seeking what you need from other places. And then my last slide is about symptom management. So again, Many different things can help with symptom management. Symptoms are very different in each person. So whatever that combination of treatments is going to be different for you than it is for someone else. But it's important to communicate with your healthcare provider if you're having worsening, if your treatment or the medication you're being given is affecting you and it's causing issues. Don't just stop it and don't go back. Okay. Let somebody know. And then there may be something else that needs to be done, or they may need to refer you over to somebody else who subspecializes in that issue. And then certainly it's important to educate yourself coming to programs like this. I love what Jody said. Google is your friend, but Google can also not be your friend. Okay. So looking up things like if you're having certain symptoms, how to describe those to your healthcare professional, right? The words to use to describe that can be very helpful because it keeps us from having to try to pull your teeth to get it out of you, what's going on with you. Also, physical activity. We're learning a lot about exercise, okay, and how it can really not only help your condition, but also keep your brain healthy, right? One of the issues that we combat with MS and NMOSD is we have something called the neurologic reserve, our ability to bounce back, right? And that decreases as we age. But there are ways that we can build that up, like exercise, like eating a healthy, well-balanced diet, stopping habits like smoking and things that are detrimental, alcohol abuse, things like that. So there are ways to build up that neurologic reserve so that you're able to bounce back better from any issues. And then, of course, if you need things like rehabilitation, important. And then if there are medicines that are needed to help with certain symptoms, being open to discussing those as well. All right, that's how you find me. I'm the Nerdy Neurologist on all platforms, including Instagram and YouTube and all that stuff. And then my last slide always says, all I need is peace, love, and a freaking cure for multiple sclerosis. I need to add NMOSD to that. And then I'll take any questions as Stuart runs around. Thank you guys so much for your time and attention. And I will take any questions you guys have.
That's right. Thank you very much.
Hopefully it was helpful.
That was definitely helpful for me to understand more.
There isn't a way that you can have both MS and
NMOSD. Right. So they are very similar, but different diseases. Okay. Now, there are some people who have slight features of both. Okay. For instance, there was an article that was presented, or an article that I read from a cohort of patients actually in South Africa who had kind of similar symptoms of both and was kind of like right in between MS and NMOSD. And so there was a question, is this a new type of demyelinating disease? But I think for the most part, people are either in one category or the other. So it's not very common that you would have someone that we truly thought had both MS and NMOSD. Now with the diagnostic criteria, we also have what we call NMO spectrum disorder, right? So where you have features that are very common to NMOSD, but maybe you don't fit the full criteria. So I think that gives us a little bit more leeway to put someone in an NMOSD category than it was before you had to say there were no brain symptoms and stuff like that. Yeah, so usually you're one or the other.
Oh, I want to ask the question. My question is, since you discovered the MSOD, have you all had any MS patient that you had to switch to?
Oh yeah. So honestly, are there people who were previously diagnosed with MS who are now thought to have NMOSD? Yes. So my personal practice is everybody that comes into me that I think has demyelinating disease, I test for NMOSD. So I test everybody. Okay. And I think that many clinicians do the same. Okay. So when we're first seeing somebody for a new diagnosis, many of us do test everybody just to make sure we're not missing something.
So that is true in urban America, but not true in rural America, which is, where we dominate our programs.
Right.
And that's the idea, to get the word out to those in the rural communities who are seeing just general neurologists who don't know how to test.
Right.
So what would you tell a person who none of the medications are working for them and they've been diagnosed as MS?
Yeah.
What could they possibly learn from this?
Yeah, so I think a couple of things. I think number one, it never hurts to take a second look. It's okay to advocate for yourself and ask your doctor to test. It's also important what type of test they do, right? So the previous test, there was a test that we call ELISA, right? Which I'm not going into detail about that. But the most important test for you to get now is what we call a cell-based assay, which is more accurate. Okay. So there have been patients who have been tested for NMOSD with the old test and it said negative. And then we retested them with the cell-based assay and they actually were positive and able to qualify for some of these treatments. So if a person is concerned about NMOSD, it doesn't hurt to ask your doctor to test, but make sure also that they're doing the cell-based assay because that's the one that's the most accurate.
Question over here.
Yep.
I don't know if you already said it, but what is the prevalence of NMOSD?
I don't think I did say it. So 2 out of 100,000, I think, was what we saw. With MS, is higher than that, but it's still a very rare disease. So it's much rarer than MS. So for instance, even at, when I was working at a very large private practice MS center where we had like 4,000 to 5,000 patients a year, I maybe had 10 to 20 NMOSD and hundreds of MS patients.
Can you explain the B12 with the MS or the NMSD?
B12, why we check for B12?
Yeah, what is that?
Okay, so B12 deficiency, if it's very low, can cause certain neurologic symptoms like numbness and tingling. And if B12 is low for very prolonged periods of time, it actually can cause damage to the spinal cord. Now, most people in industrialized nations don't have severely low B12 deficiency over prolonged periods of time. But many people who come in with demyelinating disease will have numbness and tingling. So essentially, we're trying to rule out that as a potential cause or contributor to some of the symptoms. So we always check B12.
Yeah, first I was going to ask about, was it a spectrum like MS, but you already said it is. I was curious, you said that
NMO.
Yes.
Or you could just say DeVix.
Yeah, okay. They say that that's more prevalent in Asian and blacks, whereas MS is not, except for in the United States.
Well, that's all we know because we don't study people in Africa.
Oh, I was going to say, did you know why it's more just the United States, but it's because you don't know.
Well, United States has the most black people out of the places that are studied, right? So there aren't a lot of research studies that are conducted in continental Africa. That is something that many of us are working on. There are MS centers that are now being recognized where some research is being conducted, but because the U.S. has the largest Black population out of most of the places where clinical trials are done, then that's why we're seeing such a prevalence, because people are actually being studied here. Versus in Eastern Europe, the populations are much more homogeneous, so we don't see as many diverse groups to be able to study and understand the prevalence. Excellent question. Yes.
For folks who have NMOSD but are seronegative, what is what's like the maintenance strategy between relapses? Is there any medication for that?
So usually that's where we use rituximab. Okay. So again, rituximab is not FDA approved for MS or NMOSD, okay, but that has been the primary treatment that we've used for people who are seronegative. We use it for everybody before there was a test, but for seronegative people, that's the most common one. Yeah.
Okay, do we still not know why it's more prevalent, both of these more prevalent in female than male?
No. So there are some questions about whether it is related to hormones, right? So there are a lot of studies looking at estrogen. There were some studies looking at different types of estrogens as what we call adjunctive treatment, right? Adding on some estrogen to your DMT. But the answers are not quite definitive. We do know that all autoimmune diseases are more common in women, and we're not really sure why.
I was going to ask, I'm negative B12, but I have MS, but it's because of my anemia. That doesn't have anything to do with the other
So
disease.
B12 does not directly correlate with MS or NMOSD. Right?
Okay,
So B12
that's my
deficiencies are not due to demyelinating disease or a symptom of demyelinating disease. But again, we have to rule out other reasonable causes, right? So if someone comes into my office and says, I'm numb and tingling, okay, which can be a symptom of transverse myelitis, but it can also be a symptom of B12 deficiency. So that's why we check. But these diseases do not cause B12 deficiency and are not directly related to B12 deficiency. That's an excellent question.
Are these neurological diseases more prevalent in any particular part of the world?
Are they more prevalent in any particular part of the world? So we don't have as much data with NMOSD. Okay. We have more data with MS. So if you look at the prevalence maps for MS, the highest prevalence is in Eastern Europe. Okay. The second highest prevalence is going to be Canada, and the US is going to be right after that. Okay. But again, also keep in mind that many parts of the world, which are considered less developed, do not have access to research. So we used to say MS does not occur in Africa, which the numbers we have are low, but we don't have a lot of research going on. So honestly, some parts of the world, we really don't know the prevalence because we don't have access to research in those areas of the world. But as far as we know with MS, Eastern Europe, Canada, and the US.
Recently, my doctor told me I'm using too much B12. It made me feel good.
Well, so again, when we look at B12 levels, right, there's a certain range we want people in, but sometimes the labs come back and the number is off the scale, right, where it's red. So if I get a lab and it says greater than, and it's in red, meaning they can't measure it, then that means you're doing too much, right? You need to back it up a little bit, okay? Now, generally, if you take certain vitamins, your body uses what it needs and you kind of pee out the rest of it. I was trying to think of urinate out the rest of it, right? But again, we don't want people to have toxicity, right? So if you're taking too much, you can get issues from having too much of a good thing, so to speak. So we always get a little nervous when it's off the scale, right? So when it says greater than, that means they can't measure it, then that means we doing a little bit too much.
What is the side effect of too much B12?
So honestly, the side effects would be, I'm not really sure because usually I make people stop it if they're doing too much. I'm not sure the side effects of vitamin B12 toxicity. We will definitely look it up.
Okay, so coming off of that, what about the affiliation between D3 levels?
Yeah. So vitamin D is also, so there's been a lot of controversy about vitamin D in MS. We don't talk about it as much with NMOSD, but with MS, every conference I go to, everybody's like, vitamin D is a thing. And then you go to the next one, it's like, we're not worried about vitamin D. So we talk a lot about vitamin D because it has immune function, right? And we know that low vitamin D is a risk factor, particularly for multiple sclerosis, okay? We would assume maybe also for NMOSD, but we haven't really gotten to risk factors for NMOSD like we have for MS. So we know low vitamin D is a risk factor, so we always want to replace it if it's low. Most people with MS, and honestly, most people, period, have low vitamin D levels. I probably have met one patient in my whole career with normal vitamin D that was not on supplementation. And I think he was like a surfer, right? He's like always out in the sun surfing or something like that in California. Right. So because most of us are not out in the sun, particularly my MS patients, because sun bothers them. And then most of us don't just drink gallons of milk like my 6-year-old that drinks a cup of milk every night before she goes to bed, right? So we're often not getting enough vitamin D. So again, we want the levels often somewhere between 40 and 70. Okay. But if people are taking vitamin D and I get lab levels where they're off the charts, then usually we try to back up a little bit. Okay.
Oh, in the event that B12 is not, you have too much B12, what other items can you take to supplement if it comes to energy and everything?
So I cannot give you specific medical advice. But when we talk about energy, there are multiple things that people can do to help improve fatigue. All right. Fatigue is often multifactorial. Sometimes people say B12 can help give them some extra energy. Sometimes you're fatigued because you ain't sleeping at night, right? And anybody that's not sleeping at night is going to be tired, right? So, you ask Dr. Mitzi for a pill, but you sleeping 2 hours a night, right? The pill ain't going to fix it. You need to go to bed, right? And then so we work on things like sleep hygiene, also things like exercise can improve fatigue. And in some cases, there are stimulant medications that we can use for fatigue. Again, every person's, secret recipe for their MS is individualized, but it's important to talk to your doctor because there are some medicines that may help. Again, any medicine comes with different side effects, etc. But those are usually the ways we manage fatigue. Lifestyle modification is the first line of defense. And then, of course, looking at medication options if we need them, or adjusting other medications, because some of the symptomatic medications that we use for MS and NMOSD can also cause fatigue, right? So we always have to kind of walk that line between the symptom management to make sure that the treatment is not worse than the problem or not significantly causing other problems to be worsened.
So what I know, and most of us know with MS, three of us could have MS. She could be numb on the right side. I could be numb on the left side. He could have eye problems. With the disease that you were talking about, is it other than the eye variants, is it similar? So if there were three, we would all experience pretty much the same, or is it more like MS where it could be different?
So there is, again, a lot of variability. I think the major differences that we see with NMOSD versus MS are, again, the characteristics of the MRI are key because the MRIs do look very different often with NMOSD versus MS. The antibody test, can be helpful in differentiating the two. And then one of the other hallmarks is, again, the severity of relapse. So optic neuritis, one time, blindness often with NMOSD versus MS, people will have significant recovery from relapses, even if they don't have full recovery. So, having a clinician who specializes, so I did a fellowship in neuroimmunologic diseases. So having a physician who specializes in MS and NMOSD can be helpful if there are concerns about differentiating the two. But certainly, there can be variability in the symptoms. Oh, that's not what you were asking. I'm sorry. Okay.
What I'm saying is, like, three of us, say if we have MS, we could have all different symptoms at any one time. With the other condition, would it be the same thing? This person's symptoms would be different from mine, would be different from hers, or is it all like the same?
So yes, they would be different. Yeah. So yes, they can be different, but the common themes are blindness and paralysis, unfortunately. So a lot of my folks that come in either can't see out of one eye, can't see out of both eyes, or they can't walk, or sometimes both. So again, even though they may have started with different symptoms, oftentimes by the time they get to see somebody, their presentation is a little bit similar. It's either the eyes are gone or the legs.
Okay. Thank you. And we have a new last.
All right.
With the patient that we heard from today, she said when she went online and she looked up her symptoms and she was 54, they said, no, you don't have MS. So why was that such a determining fact? Because I know with a lot of other patients that I've talked to, they kind of sometimes, they have like little things that happen earlier in life and they just kind of blew it off, or a doctor didn't have an answer. So she could have maybe had some other things happening earlier, but also I'm getting older and all of us are getting older. What does age in MS look like?
Oh, honey, if I knew that, I'd be a rich woman and would be laying in the shade sipping lemonade. What I will say is that we are learning a lot about MS in the aging population. Okay. Again, when we come up with diagnostic criteria, and I say I didn't specifically come up with the diagnostic criteria. There's a range, right? So there has to be a range because you have to have something to try to characterize a disease. MS has always generally thought to be people ages 20 to 40, okay? And so when people are in their 50s and getting diagnosed, or their 60s, we used to think that was outside the range. Now we know that the largest population of people living with MS in the U.S., at least right now, is ages 50 to 60, okay? Mid 40s to 60s. So we are learning that, of course, there are always people that fit outside of those barriers, but we try, diagnostic criteria is created to try to give you some kind of guidance, right? Otherwise, if somebody comes in with tingling and they're 90, we'd be looking for MS when they really have neuropathy from their diabetes, okay? So that was the traditional thinking. We're learning about MS in the aging population. I think, some of the big pushes for us in the research community are to make sure we're including people who are over the age of 55 in our studies. Let me say 55 is not old, okay? Just for GP. It was an arbitrary number they just came up with, right? But 55 is not old, okay? But for the purposes of our research, all of our research goes at 55. So we really don't know what happens after 55, okay? So we're trying to better understand that. And we're trying to understand what happens as the immune system ages, right? So in a younger person, usually their immune system, other than this overactivity, is intact. But now we have to try to figure out what happens when we're giving you medicine that affects your immune system, and your immune system ages and it doesn't work like it's supposed to, and your neurologic reserve, or your bounce back, is decreasing, right? So when we mix all that up together, what does it mean? And the honest answer is we don't know. There are a couple of large studies for MS that are going on. I believe one is Cleveland Clinic and one is at Mayo Clinic, where they're looking at MS over the age of 55 and what to do with treatments, if we need to stop treatment or what happens when we continue, but we don't have the results of those studies yet. So there are people that are diligently looking to try to better understand, but those are some of the issues that we're encountering that we're concerned about, because we want to make sure that, number one, treatments are giving people benefit, but that we're not causing more harm, than good by making you subject to infections and things like that.
Hi, my daughter, she has NMO. We were told that it's not hereditary, but she also has her auntie that has NMO. Her father passed from lupus, her grandmother passed from lupus, and her great auntie was diagnosed at 86 with NMO. What is the likelihood of it? They say it's not hereditary, but it's got to be something there.
Right. So when we say something is not hereditary, that doesn't mean it doesn't have a genetic component, right? So when we think of something as being hereditary, we think like sickle cell. You got a gene, dad got a gene. We can predict 1 in 4 of the kids will have the disease, or we can predict what percentage of the kids will have the disease. With diseases like NMOSD and MS, for instance, with MS, there are over 200 different genes and different combinations that can affect risk, okay? But it's not something that is directly passed from like parent to child. What we more commonly see is that autoimmune diseases run in families, right? So I have a cousin who has MS, her mom has rheumatoid arthritis, and her aunt has lupus. So that's more commonly what we see than necessarily people having the exact same disease. Are there some families where multiple people have MS, like brothers and sisters or parent and child? Absolutely. But most commonly we see if it is in the family, is very sporadic, right? So it'll be a child, it'll be an aunt, or it'll be a second cousin or a third cousin, right? So again, it's not something where we can predict how it goes from this person to that person. But as I said, more commonly we see multiple autoimmune diseases in families versus just that disease. So not hereditary in the sense that you can pass it on, but can those things be more common in certain family groups? They can.
Thank you. I think we've reached our final last.
All right. Thank y'all. Y'all got me up here sweating and carrying on. And
thank you very much.
Thank you very much for your time and attention, guys.
Thank you, Doctor.
And thanking you, Stuart, for inviting.
Thank you. Thank you all for coming.